Good morning, everybody. We're having a technical issue as I am unable to link up. There's Carolyn. There you are. Great. Good morning.
It out. I'm so proud of myself.
Keep going, Carolyn.
Oh, man. You don't even know. It's like Harvard time. Oh, good morning.
Good morning.
Good morning. Good morning. Question time. What do you think? Yeah, I think that's a yeah. Okay, well, everybody here's ready, and so am I. Number 1 comes in saying, "Good morning, Dr. Rosensweet. Would you know if one uses topical biased, if this would be a reason for the labia to swell? And if so, what would this mean?"
Good question. I think the issue becomes if you're applying estrogen directly to the labia, or, for example, testosterone to the clitoris, can there be swelling? And the proof's in the pudding, so to speak. I mean, you apply it, and if your labia swell, then, of course, it caused it. Excuse me 1 minute. Let's see, I want to make sure I've got everything technically going here. I know for sure that testosterone applied directly to the clitoris can cause enlargement of the clitoris.
Right.
Or another way to look at it is very often the clitoris atrophies or becomes less in menopause without the support of the natural hormones. Thus, when you are restoring testosterone, for example, no matter where you're applying it, or especially to the clitoris, you could get return to normal size of the clitoris and return to normal function.
Right. What about biased, though?
Well, biased is definitely estrogen. In 25 years of specializing in this with women, I have not heard this question arise. I've definitely heard the enlargement of the clitoris or the return of the clitoris to normal with the restoration and replenishing of testosterone. But that's why I hedged my response there with, well, if you are applying bias directly to the labia and you're getting enlargement or swelling, then there you are.
Right.
Now, this does not mean necessarily that there's an improper dosage. And we recommend that a woman does not apply bias intravaginally or on her labia because it interferes with the 24-hour urine hormone test.
Right.
That is the reason why.
Oh, good. Okay.
Now, there's a second reason. If a woman is having actual intercourse with penetration, a little bit of estrogen is fine on a man. You know, some men actually need a little estrogen, and it's protective to the arteries. But too much to a man, no, we don't want a man picking up excessive amounts of estrogen, which can happen, and we can see excessive estrogen when we test men. So just know it's a possibility. So any woman who's having intercourse, I would definitely recommend that she do not apply estrogen biased, whatever form you're talking about, intravaginally or on the labia or the clitoris. It will
Got
be
it.
transmitted. And let me give you an idea how it's transmitted. We have done actual transmission testing. We have someone, bless her heart, was willing to let us apply some biased to her lateral thigh. And we did a before sample, and then a sample at every 15 minutes, then every half hour, then every hour. We submitted this to the laboratory, and they did assays for how much estrogen was remaining on the skin. And what we found is that within 1/2 hour, 95% of the estrogen was absorbed.
Whoa.
And the basic question is this, is if a woman applies bias, for example, to her forearms and then hugs her 10-year-old daughter, or anyone for that matter, is she going to be transmitting that? Yes, she will. If she puts it on and then hugs immediately. With our organic oils, you can so easily see that these oils absorb so fast. I mean, you rub them in a little bit and you're dry. Your skin is dry. But in actual testing, it takes a half hour before 95% of it is absorbed. In other words, when we swabbed that area after a half hour, there was only 5% of the original dose left on the skin, and by an hour, it's almost all gone. Now, if a woman has applied the bias to her forearms and wants to have intimate contact or touching contact with anybody, or intimate contact, or where it gets most relevant, she can always just immediately wash with water, or soap and water, even better. We've tested that. There's zero residual when you wash with soap and water. Not a vigorous, intense wash with soap. No, just a simple, rapid wash. Because this is the issue of transmission. For example, we had one of my patients about 25 years ago, actually, apply testosterone below the knee, apply her hormones below the knee. And we never recommended that. I say that you should not be applying these hormones below mid-thigh. This relates to veins and stuff. But this woman did, and she had a dog that when she would apply her hormones, the dog would lick her legs, lick them off her legs. This is back in the day when we were not using the organic oils. And she started observing behavior, shall we say masturbatory behavior, in her elderly dog that hadn't dreamed of doing anything like that for many, many years. So these hormones are transmissible. That's my point. But with a little bit of caution, you don't even have to think about it. But let me talk about intravaginal. Commonly enough, if there's severe vaginal atrophy in a younger woman who's having intercourse, or in a woman who's not so young having intercourse, at the very onset of the treatment program, we'll not only do the bias applied to her forearms to get general circulatory estrogen into her body, we'll do 1 bottle of estriol and have her apply a drop or 2 at night, or sometimes even twice a day, of the estriol intravaginally. This will facilitate the recovery of the atrophied vagina. We never have to go more than 1 bottle, because by the time that bottle runs out, or even before that, there's been sufficient recovery of vaginal tissue. It's really remarkable.
I was going to say, it's amazing.
And and I once prescribed this regimen for a woman in her late 30s, because she had premature menopause and she had severe vaginal atrophy, and she loved her husband and they were having active intimate contact. And so she did that extra application of estriol to her vagina. And then because she had improved so much symptom-wise, we had reached the point where we wanted to do a 24-hour urine hormone test. And her being a rigorous of scientific mind, not a scientist, but of scientific mind, she said, prior to collecting the urine, because I'm applying this in my vagina, and the urethra, the urethral meatus, the tube that goes from bladder to actually empties into the vagina, she said, do you think there'd be any cause for contamination there? Should I omit the vaginal estriol prior to trying to collect the urine? I thought that was pretty brilliant because I knew she was right about that.
Oh, yeah.
And just to confirm how long we thought she should omit, I contacted the PhD owner of the wonderful lab that I use and asked him, how long do you think she should omit the vaginal atrophy to make sure we don't get estriol contamination direct into the urine? Because we want to measure, we want to get an assessment of the total body estriol. We don't want to get any direct assessment of estriol. And he said 48 hours. And she, my patient, omitted 60 hours. No estriol intravaginal for 60 hours prior to beginning collecting her urine. And when we got the test result back, she had astronomically high estriol levels, obviously from direct contamination from the intravaginal estriol. It was still in the vagina. We think of the vagina, and I know it's true, of it being an excellent absorptive surface. It's a mucosal surface. Mucosal surfaces almost universally absorb better than skin. Skin absorbs great, but mucosal surfaces absorb even more. However, so we would have expected that by 48 hours, there would be no trace of the intravaginal estriol. However, that was not true. There was residual estriol in the vagina 60 hours after she had applied it.
Wow.
So the moral of that story is I never recommend intravaginal anything. Or if I do, to accelerate recovery, I'll wait a couple weeks prior to having a woman collect her urine when we want to get a general body assessment of urine. So yeah, the main reason that we do not recommend intravaginal application of anything is because of the 24-hour urine hormone testing is so crucial. It's so critical for the long-term safety and efficacy of treating a woman in menopause. Or there are exceptions. If we want to assist and facilitate a more rapid recovery of the vaginal mucosa by giving intravaginal estriol, or a woman can easily do the initial bias, because the bias that we prescribe in this bottle is 80% estriol. And estradiol is good for the vagina too. So more often than not, we'll recommend that a woman just use a drop or two of her bias at night when she's laying down, applied intravaginally. But yeah, we'll do that. We'll definitely facilitate the atrophy, but we'll wait a couple weeks of no vaginal application prior to assessing the total body. And long-term, there is no long-term need to apply vaginally. Now, I have esteemed colleagues who will recommend intravaginal application. There's reason for that. It's related to something called dermal fatigue, but I don't think I want to drift quite into that subject right now, because I think I've just turned on the fire hose of information once again. I'm not here to overwhelm.
I like that name. Oh, yeah. The fire hose of information.
Yeah.
And it's always great information. So as far as I'm concerned, you can just talk away and I will listen, and we all will. It brings me to another question that I actually didn't ask, but is it okay to apply our biased behind the knee?
Well, I don't know the exact answer to that. I know it is being recommended. I do not recommend it. And part of it is legendary in the world of women and hormones is this glitch that can take place called thrombophlebitis, and it tends to take place in the veins of the lower extremities, i.e. below the knee. There's an inflammation in the veins. You can even get a clot in that inflamed vein. That clot can even break loose and hit a lung, in which case it's called a pulmonary embolus. So I'm so shy about that I see no reason to apply it below the mid-thigh.
So
now, is there a direct effect that I could prove from the application of biased or progesterone below the mid-thigh? No, I cannot prove that, but I also see no reason to go below the mid-thigh, and especially to the back of the knee, the popliteal space there.
Right, exactly.
Because there's lots of vessels back there. And so I don't want to get these hormones near the vessels, even though I may not have the exact science on it. I don't see any reason to go below the mid-thigh, so we never do.
So
when a woman gets thrombophlebitis, and the most common way that she gets it with respect to hormones is young women who are on the birth control pill. That's oral estrogen. It's orally administered estrogen. And if you go into the medical literature, there's a distinction made between orally administered estrogen, putting a woman at risk for enhanced coagulation for reasons, thus thrombophlebitis. And there was a significant number of young women who took the birth control pill and still do and get thrombophlebitis. And it's from the oral estrogen. However, 25 years of specializing in this, I had two women who told me this story, that when they applied the hormones, they got a little discomfort in their lower extremities, just like when they had their thrombophlebitis when they took the birth control pill. So I never say never, in the sense that, yeah, medical literature says no problem with topical, no thrombophlebitis, no enhanced coagulation from topical estrogen. But then, are there exceptions? Yeah, I know of two of them. So we're cautious with this. We were able to eventually administer hormones to these two women without them getting their lower extremity discomfort, and we did ultrasounds in their veins. I mean, I was concerned they were getting thrombophlebitis, so they weren't. But an expert in this, someone who's deeply trained in treating women in menopause, is going to know about all these exceptions.
Oh, absolutely, yeah.
But I say, why mess below mid-thigh because of those two exceptions? I don't want any estrogen near these lower extremity vessels.
Got it. I know that in your book, Happy Healthy Hormones, you do get into where there are areas where we can apply our bias very, very well. And so get the book.
Thank you, Carolyn. Exactly. We get very specific about that. And there's lots of areas to apply these topical hormones. You will not run out of real estate to apply these hormones.
Exactly. And I'm glad you brought up the animals too, because we tend to forget our animals maybe, and that we could be applying our hormones to our animals if we don't wash our hands, whatever, I don't know.
And just because we're on that topic, where I got challenged was I was treating a nurse practitioner whose husband had been a research pharmacologist involved in the original formulation of the birth control pills. And he contacted me directly. He said to me that you're asking my wife to apply these topical hormones, and she happens to share her clothes with our daughter,
Uh-oh.
who's 12. And don't you think, he said, my opinion is our daughter is at risk for picking up some estrogen when they share their clothes. So we have specific guidelines, and it includes applying the hormones, don't hugging anybody, don't put on any shirt if you're sharing it with your daughter for a half hour, or leave them on there for a half hour. You will absorb 95%. We've shown that through specific studies. So just wait a half hour, or after a half hour, wash off your skin that you're going to slide into your shirt that you're going to share with your daughter. Just to get.
I can hear that male cow is not happy about like the thought of having any hormones near him.
Oh my God, you speak cow no less.
I do indeed.
Because I heard the same thing that you did. Yeah.
Not a happy cow in regards to hormones.
Trying to warn us, don't be applying hormones to our loved ones unless you.
Right. Sorry, it makes me laugh. Okay, so well, thank you for that answer. This is a question I've never seen in my life. May we please visit FSH scores, meaning follicle stimulating hormone scores? I, the questioner says, think this is very important, just like all the other hormones, as I think that once you see it, the FSH coming down and out of menopause range, does this mean that you're still protected? Or does it matter?
Well, yes, let's meander around the whole topic of FSH.
Okay.
The orchestration of biochemicals in the human body is just astounding. Like the ovaries producing 4 hormones, the adrenals producing hormones, the thyroid glands producing thyroid hormones. But they're not the origin. They're not the only part of the circuitry that dictates or that inspires the amounts of hormone to be produced, the amounts of hormone to be released. No, that's related to a gland at the base of the brain called the pituitary gland. The pituitary gland produces hormones, and those hormones travel to the ovary and tell the ovary, this is how much we think you should produce. This is, it's just exquisite communication.
It's amazing.
And of course, it doesn't originate there. The pituitary is being communicated to by the brain. Initially, as we back up the trail there, from the hypothalamus in the brain. So there's actual biochemistry and electricity traveling down nerves coming from the hypothalamus going to the pituitary. So, it's just staggering. How amazingly this is orchestrated. But let's just talk about the pituitary. The pituitary produces 2 hormones that relate to the ovary. One of them is called follicle stimulating hormone, and the other one is called luteinizing hormone. And the nomenclature derives from an event that takes place in the ovary called the production of an ovarian follicle. And it's within that follicle that the egg lies. And the egg is surrounded by cells. And those cells also produce hormones. So they envelop the egg, and they also produce hormones. And the principal hormone associated with stimulation from follicle stimulating hormone is estrogen. Follicle stimulating hormone, estrogen. And luteinizing hormone coming from the pituitary gland really relates to the production of progesterone from the follicle that surrounds the egg. So if an egg is released, those cells become progesterone factories and produce about 100 times more progesterone than there is estrogen. That's how much the female body loves progesterone. It does call for that egg release. If that egg does not release, then there is no significant production of progesterone. So anyway, it's all orchestrated. So what happens in a woman as her ovarian hormone production diminishes in this new era, there's a new era going on. For almost 200,000 years, there was an old era, and almost 200,000 years of the old era, in which women and men didn't live into our 40s and 50s. So there was no such thing as menopause, for example, or a man losing his erectile function unless there was some severe accident or something. There was no andropause. There was no menopause. That I would call the old era, BNE, before the new era, or ANE, after the new era in which we started living longer.
AE and NE.
And here we're talking about agriculture producing more available nutrition. We're talking about hygiene. Simple hygiene made such a difference to the length. And we're talking about many other features, like I would say the biggest contributor to longevity is the hot shower. That's a personal opinion. It's a personal preference. I'm just kidding. There's no scientific data on that.
I was going to get a hot flash.
But I think the hot shower is the most significant human invention that there is.
Yeah, at least it's not cold.
So,
back to the question.
Back to the question. So, as women started living longer, the female body was not designed to keep producing eggs or to keep getting pregnant. One could make a strong case for the wisdom of that perpetual having babies isn't so ideal for male or female after a certain age. I'd say the 40s is a pretty good guess. And at that point, we move into the grandparent stage, which is a super valid human, societal, community, familial need. We don't need to be having babies to join our grandchildren.
It happens. Okay.
It happens, but I wouldn't say that it's terrific.
No.
So there's a common sense says it's a good idea to have an end to getting pregnant. So as the ovaries wind down their production of hormones, there's still something, and I guess there's still something very primal within us that says it's going to try and revive those ovaries. But here's the science, and this is how I metaphorically picture it. The pituitary gland, the hypothalamus, notices that the ovaries have declined in their hormone production, and say, we gotta. The human race is dependent upon more babies. That's an extrapolation of. There's no science behind this. I'm not trying to animate the thought like the pituitary has a brain, but I picture the pituitary saying, you're not going to sleep, ovaries. The human race is dependent upon you having babies, and it tries to keep those ovaries alive. And in the perimenopause and in the menopause, the FSH produced in the pituitary gland starts rising. In fact, it reaches really robust heights that's never seen in a young menstruating woman, as if the pituitary gland was really serious about keeping that ovary going. And thus the FSH and the LH rise to these very high levels. Like, for example, they're often less than 10 in a young woman, although it varies throughout the cycle. They can go above 100.
Yeah.
These are really major, we're increasing something 8 to 10 fold
We're just
and
going to
and here's the
procreate.
thing that's really interesting to me. It never stops. When I test 80-year-old women, 90-year-old women, that FSH can still be super high. And I've always asked myself the question, isn't it amazing that a woman's pituitary gland never gives up? And by the way, isn't that an unusual strain on her pituitary gland to have to keep producing these astronomically high levels of FSH and LH day after day after day? Is that healthy? Well, a common way that we can assess through testing of whether or not a woman is in menopause, though I never do it, it's extremely rare that I'll ever order an FSH or LH because it's so easy to tell if a woman's in perimenopause or menopause just from her story.
Yeah.
Therefore, I don't draw upon someone, an insurance company is expending the money for FSH or a woman out of pocket. I don't need the FSH and the LH, so I don't order it. It's not routine in the menopause method. But sometimes women show up with these elevated FSH. And of course, yes, that's correct. Your pituitary gland is trying to revive that ovary and it'll never stop. And so the FSH is elevated, and so is the LH. Now, an interesting piece of recent information is that this could be related to weight gain. Now, there's many moving parts in weight gain in a menopausal woman. And the pharmaceutical manufacturers are developing, I don't know if it's out or not yet, a drug to lower the FSH, a pharmaceutical medication to lower the FSH in the hopes that this will lead to weight loss.
I've read something about that, but I didn't relate it to FSH. Yeah.
And one of my dear and esteemed colleagues, the father of the origin of bioidentical hormones in the United States, Dr. Jonathan Wright, he and I had this outrageous laugh as he said to me, gee, why don't you use nature's FSH lowering substance called estrogen?
Go figure.
Because you cannot patent it.
Right.
Because the thing that lowers the FSH is adequate estrogen, whether it's coming out of the ovary or whether you're applying it to your skin. Notice I'm not saying swallowing it because no woman should be swallowing estrogen. Very rare exceptions.
Agreed.
So, yeah, it's fun to see the FSH come down when you replenish estrogen. Yeah, the pituitary goes, oh, things are restoring to BNE before the new era. They're restoring to normal. Well, yeah. So the FSH will come down, and it is an indirect way to test by blood testing whether your hormones are getting absorbed, but it's totally unnecessary because 75% of the women, when they start losing these ovarian hormones, they have raucous or moderate, pretty rare to hear mild, very substantial life-altering symptoms of hot flashes, night sweats, can't sleep, can't think clearly, vagina dries up, and on, bone loss that they don't know about, but it's going on. So there is no need to, for me, any time to get FSH and LH. And then we always assess by the gold standard, to me, woman's hormone levels by the 24-hour urine hormone test, usually 3 to 5 months into the hormone replenishment process. So there's some information about FSH.
Well, and A and E and NE and all that. That's a new one. If be in the medical books.
It's actually brand new.
Well,
generated by our conversation.
Correct. We could put it in
the new era, which is everything after 200,000 years.
Right, when we met. Okay, so yeah, I got that one. A couple of questions did come up. I'll get to those in a second. this question here, the questioner says, can we take bias, but really, how important, I mean, like really how important, she says, is it also to take DHEA and testosterone? My doctor will give me biased only and progesterone, but refuses to give testosterone and DHEA.
No, dun, 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 dun.
I have a drum set over here.
So a story that I've told here before is I'm a senior medical student. I'm sitting in a noon lecture. A gerontologist shows up and says to us, "You senior medical students, you know thousands of diagnoses." Gerontologist is a physician that specializes in treating the elderly.
God bless.
And the gerontologist says, "Let me tell you what's really going on with the elderly. They're losing their muscles. We call that sarcopenia. And they get unstable on their ability to stand or walk. And they fall onto bones that have lost their strength. And they fracture those bones. And back in those days, most of those folks died. Hip surgery is so sophisticated these days that that's no longer the case. But they usually die within a year of hip surgery these days. The gerontologist says, you want to do something for the elderly? Take care of their sarcopenia and their bones. And so at that time, I did not know this information, and that gerontologist did not mention this. But here's why the elderly lose their bones. Well, let me say this. You don't see a tremendous number of elderly in their late 80s and 90s walking around. And I spent 20 years in Florida near beaches. You don't see a tremendous number of late 80s and 90-year-olds walking those beaches. And when you do see them, you see these extremely thin thighs and calves because they have lost muscle. And what's going on in the majority of the elderly, if they go down to the floor to play with their grandchildren or for whatever reason, they have a tough time getting up because they've lost muscle, actual muscle mass in their lower extremities and everywhere else. And one of the common complaints of a woman going to menopause is she points to her forearm and blots the triceps area because once there was muscle and now there's fat. Sarcopenia. Right.
Yeah.
And when a woman gets sarcopenia of a wonderful sacred muscle called the levator ani that holds up the bladder and the uterus, that bladder and uterus start to fall and contribute to loss of a woman's ability to hold her urine, otherwise known as incontinence. Vaginal atrophy is the other major moving part in that. And so adult diapers are very common. They're called, when you go to a grocery store or a pharmacy, you'll see a lot of real estate taken up by adult diapers.
The whole aisle. Yep.
And this is from sarcopenia, loss of muscle. And this is almost universal. If you see thick thighs on an elderly person, that's usually not muscle. That's usually from being overweight. But all you have to do, in fact, this is a test I do in my office, or I haven't had, I'm doing everything, all menopause treatment by telemedicine. I'll be sitting there on a Zoom call and a woman will be sitting in her chair. And what I ask her to do is stand up, not using your hands. Get out of that chair, not using your hands. And what do I see? They're having challenges getting out of a chair in their 50s or 60s even. Sarcopenia. Now, I've always, and in order to preserve the muscles, yes, exercise is important. And it'll take you a long way. But for so many women, it is not, N-O, not, N-O-T, not, sufficient to preserve the muscles. You need androgens. You need testosterone, minimal. DHEA is an androgen as well, but you need the testosterone. I've always, in recent years, I felt the greatest service that we are giving to treating women in menopause is the replenishing of androgens, because that will keep the majority of women out of canes, walkers. The transitions from walkers to wheelchair. That's the place where it almost becomes unmanageable when coupled with the incontinence at home, and they have to make a transition to an assisted living facility and nursing home. Now, estrogen plays a huge role there too, because the cognitive decline that can take place so severely for many is the other thing that gets women into nursing homes and assisted living facilities. God bless the nursing homes and the assisted living facilities, all their amazing, heart-touching workers. But at the same time, the women would rather not be going in there. They like staying at home, the vast majority of them. And it's very challenging, as it was for my own mother when I could no longer take care of her at home. And Dr. Lindsay Berkson and I we've discussed this, and Dr. Berkson was just reminiscing about the possibility of what would happen to American healthcare if the hormone replenishment in females and males was universal. Would there be 10% of those who had to go into nursing homes, or 20%, and 80% or 90% would be spared? What would be the impact of healthcare and Medicare, et cetera? Would it be that we wouldn't threaten our whole medical care system because the end of life costs in nursing homes is just astronomical? So I strongly assert that every hormone that you have diminished, it matters greatly to you that you replenish them for your whole life, from menopause on, males and females. And the androgens, testosterone and DHEA, are absolutely as crucial as the estrogens and the progesterone. All of them. And if you're low in thyroid, which so many are, that needs to be replenished too. These things really matter. These are our power chemicals, and they have such profound effects. So what do? We copy nature. And a menopausal woman does not need a 20 to 29-year-old woman's levels. Almost universally, there are exceptions when it relates to cognition.
Yes.
But replenish those levels to menopausal levels. And they're not youthful levels. We don't need to. We don't need a woman to menstruate. In almost all cases, there are exceptions. So anyway, go on those estrogens, progesterone, testosterone, and DHEA, and do it and get it right, and get those levels defined by testing, by expert testing, by 24-hour urine hormone testing, the only testing, in my opinion, that's going to get you there. And do them all. And, nature did not design DHEA and make it the most prevalent milligram for milligram hormone or prohormone or whatever you want to call it in the female body for someone to make a statement. With all due respect, I'm not going to replace the DHEA and the testosterone. DHEA, milligram for milligram, is more DHEA than there is all the rest of them. So, do we want to just say, well, let's just neglect the DHEA because of? No. We replenish all these hormones, and so I hope I've said that loudly and clearly enough. Get them replenished and get it right.
Yes, and I'm seeing questions coming up, and it gets my heart. It honestly does, and that it does. And we don't have elevators here, and many people will come saying, "Please, can we live on the first floor?" Because they can't walk up the steps. And I just have to stay quiet
There you go.
Right?
Watch an older person, 60s, 70s, walk up the stairs. Sarcopenia. And sarcopenia can be prevented.
Correct.
And the earlier the better.
Right.
But we never say never. We have a video somewhere in our vast videos warehouse of, at the time, my late 80s mother-in-law who had taken a fall in her kitchen, fractured her humerus, that's her upper arm bone, her clavicle, and her pelvis in rehab for 3 months. And by that time, she was using a walker. And because of sarcopenia. And when she got out of rehab, we put her on hormones, and we have a video of her sitting on a low, soft couch with her arms like this, standing up with this huge smile on her face because testosterone made an astounding difference to her. So never too late. She had never had a hormone in her life prior to that.
Right. And I can go on with that story because I know that story well. And it's a miracle. And it really doesn't take that long for it to start working.
Well, it's variable. I mean, the earlier,
meaning like 20
better,
years.
but I think for her, it took about 3-4 months before she got that their strength in her lower extremities.
Right. And that is a beautiful story.
Yeah.
And I've seen some pictures too, not of your mother-in-law, but some other pictures. And boy, that's something else. And it's definitely something else. Oh, yes. Well, Dr. Rosensweet did answer yes, that your skin will tighten with BHRT when we're talking about the testosterone. And Diane, I read you loud and clear, and I certainly will help and get back with you.
Let's talk about that loose skin. I see that question there. Skin changes dramatically from a young menstruating woman as a woman ages. And several things happen. And I'm not going to go into the biological details, but they are extensive. But you replenish estrogen and that skin starts getting its hydration back. Without the estrogen, your skin does not retain moisture and it gets thin and wrinkled. The French knew this. They were slipping estrogens into their expensive skin cream for decades and decades and not putting it on the label, because they knew that this would make a woman's skin look fabulous. And yes, the skin tighten, part of that triceps area flab really depends upon the restoration of musculature and how much can you restore and how much weight have you gained. So sometimes you can't get it all back and you can't get rid of all that flab. But the skin will definitely tighten, but it's primarily with the estrogens, because women say, God, I started my hormones and I gained 3 pounds right away within a week. Yeah, you didn't gain 3 pounds, but it was water. And take a look at your skin, because this will fill your skin out and make it look nice. But part of the tightening has to do with the underlying musculature, as you were suggesting there, Carolyn.
Well, we have 10 minutes. We can start placing bets. I'm kidding. My last question here on this page is, hello, I'm new here. I'm 50. I had a full hysterectomy at 37. I've tried several hormones to help me, and I do not feel well. I have no sex drive. Intercourse hurts, as I am so dry, and I have recently put on 20 pounds. So she had her hysterectomy at 37 years old, asymptomatic completely until 50. She's now being told that she's in menopause, and it's blowing her mind. She's like, how can this possibly be? I didn't ever have any symptoms. Why would all of this start appearing now? The loss of libido, the vaginal dryness, are really my two biggest concerns. But more so than that, why didn't I have any symptoms all these years?
Well, I don't know whether that was a total hysterectomy, which means the ovaries are also removed. Many hysterectomies are done. Hysterectomy refers technically to only the removal of the uterus. Well, there's no hormones being produced in the uterus. And that gets a little tricky in a woman when just the uterus is removed, because those ovaries keep on producing. So at the point where they stop producing, and they gradually decline, and then they stop producing hormones, in 75% of American women, and it may be worldwide, they start developing symptoms of insufficient hormones. And they're not mild. They're so commonly raucous symptoms. Hot flashes that wake a woman up in the middle of the night. She used to sleep in her life, but now she can't sleep. She loses her progesterone. She gets anxiety when she was doing fine. Yes, there's the challenges of life, but she would never say that she had anxiety. And on and on and on and on. Raucous symptoms are extremely prevalent at the 75% level. 25% women have the same hormone declines, but they don't pick up on these raucous immediate symptoms. They're losing their bones, they're losing their muscles, their arteries are at risk, their cognition can be at risk, and on and on and on, but it's not as apparent. And especially if a woman is overweight, because the adrenal glands continue to produce DHEA, and DHEA can be converted to testosterone and estrogen. So some of the more overweight women look around and wonder, what everybody complaining about menopause? It's fine with me. I went through menopause and I didn't feel a thing. These are the women that is, from my physician's seat, I am most concerned about these women, because they never get inspired. Whereas the women, the 75%, they get small, medium, large, or humongously inspired. They're not conducting their lives anymore. They're so compromised. Oh, they muscle through, of course, because they're strong, but boy, they get inspired. And sometimes they get discouraged because they meet up with all kinds of inappropriate information and fear and stuff. But so many of them, to the tune of probably 10 million at this point, of the probably 80 million, I don't know the exact number, of women in menopause, they find their way to get treated because they can't stand it and they like to live good lives. So what was actually going on in the questioner's body, unless she was significantly overweight, was she was definitely getting gradual decline and then loss of ovarian production. If she was significantly overweight, in her fat tissue, the DHEA and testosterone that continues to be produced in the adrenal gland can be converted to estrogen, so her symptoms would be less. But then there's all the attendant problems of the overweight. So I won't call it a strategy. I've often wondered, does a woman's body that so commonly puts on additional weight in menopause do so because it's a way to continue hormone production even at a low level? I honestly have thought of that continuously for 25 years. That the weight that comes on that is not acceptable to so many women, that it's actually physiologic. It's the protection she can have. She puts on the fat tissue that allows her to convert some of her adrenal DHEA into testosterone and estrogen, ultimately into estrogen. So it's interesting. I don't see any proof of that, but as a strategy to women who are gaining weight at menopause, let's replenish your hormones and stop that, whatever the metabolic changes are that leads to an inappropriate weight gain. So at any rate, that what the questioner didn't know is her hormones were declining. And eventually they added up to the lousiness that she's feeling now. It just took a while.
Right.
Moral of the story, when you get a hysterectomy, if it's a total hysterectomy, you went into menopause the day of the operation. And what we always suggest to women who are scheduled for a hysterectomy is prior to that operation, have an appointment with someone who specializes in the treatment of women in menopause with compounded bioidentical hormones, and have the hormones in your pocket and put them in your hospital bedside nightstand drawer. And when you wake up from surgery, put them on right then and there, because that's the best time to do it. Walk into that hospital with these in your pocket, your purse or something. Have them
anywhere. Hide them.
Once you get home, have them sitting on your bathroom counter, and don't do that surgery until those things are sitting on your bathroom counter. Or it doesn't really matter. I mean, I'm just talking about the best way to do it. Let's say after surgery, you realize, oh yeah, right, I better replenish these hormones. So you get it done then, or you get it done a year later, or whenever you think about it.
Ugh.
Find that specialist, get a program optimized for yourself, and get going on it, and stay on them for your whole life. And everything you heard about risk was the opposite of what's true. We're all at risk for all kinds of stuff, cancers. Men are at increased risk for prostate cancer. There's reasons. Women are at increased risk for breast, ovarian, and uterine cancer. There are reasons for that. But women who are treated with hormones, according to the science, it's always been true, are at less risk for breast cancer, heart attack, and stroke. No matter what you misheard, there was misinformation that exploded out into America and the world in 2002. It was wrong. It was wrong right there in the original study. Somehow it leaked out and got misinterpreted. But anyway, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Get those hormones. You're going in for a hysterectomy, get those hormones. You're having period irregularities and some symptoms of menopause, get them hormones.
DEM, hormones.
Get thee to a hormone specialist who really knows what they're doing, because it's best case scenario. It's intricate, and best to individualize it. And the key to the highway is individualization. And you can only do that with compounded bioidentical hormones. You can only do that with compounded bioidentical hormones. You can only do the requisite individualization with compounded bioidenticals.
And we are working really hard on that. Don't get me started, because I'll get all riled up again, and then that cow's gonna start going, and the birds too.
Oy, oy.
Oy, 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 oy. So the one last question that we'll lead out on really quickly, Diane asks if we can squeeze just one more question in there in the hourglass before the hourglass runs out. Can you get DHEA from the health food store, yay or nay?
Yay, but no more than 15 milligrams for women. Don't do it. Don't do 25 milligrams. Don't do it.
No.
Nope, I've got a hard stop.
I know you do, because we have.
So I have to say rapid goodbye because someone's waiting for me.
Oh no, I guess that means rapid. So we will talk to everybody on Tuesday. Have a fabulous time, Dr. R. We will see you later. Lindsay Berkson and Dr. R are going to be coming up, and we know that for sure.
At 1 o'clock Eastern Standard Time. Go to Ins and Outs of Menopause to get the link.
Right, 3 hours our time ahead. I don't know, whatever. Anyway,
okay,
you'll figure it out. Hasta la vista. See you everybody later.